Okay, we're going to begin the next session here. Let me share a few bits of information about this session. This is going to be a research-based session. We're going to look at posters after this session is done. We wanted to feature some of the best in asthma education, research, and scholarship. So we're going to have 3 presentations up here first. The other thing you'll notice is we have some lights on and so forth. Western Schools has asked us to record this, and so they're videotaping this, that they can make an enduring material from this presentation. There'll be one other presentation today that they'll be doing that for. So we're going to try to feature some of the best in research and scholarship for you. Basically 3 presentations that are doing some good things, and if you have comments and questions, you can certainly ask those. And then we'll be going to the poster sessions, awarding the first and second and third place poster winners from the poster contest. I want to really thank 2 people here in particular, Mary Martinezek and Lisa Johnson. They coordinated all these efforts here, so let's give them a round of applause for doing a great job with that. And now I'm going to have my co-board member, Virginia Thomas, kind of introduce the first speaker. Thank you.
Good morning. It's my pleasure this morning to introduce Melinda Shula. She's going to be addressing the topic, National Asthma Control Demonstration Project. Melinda's really an outstanding speaker. She's the Regional Clinical Director, Supervisor, and Principal Investigator of the Regional Asthma Disease Management Program of Missions Children's Hospital, and she's located in Asheville, North Carolina. The program is really recognized as one of 13 national asthma demonstration sites by the National Heart, Lung, and Blood Institute. In 2012, the program was awarded the U.S. Environmental Protection Agency Healthcare Provider National Asthma Award. Linda has many degrees. She has a family. She's hardworking. She's a great person. It's my pleasure to introduce to this time Melinda Shula.
Thank you. Good morning. It's a pleasure to be able to present to you the Regional Asthma Disease Management Program of Mission Children's Hospital, a population-based healthcare initiative. I would like to take just a moment to share with you the story of Johnny, a 6-year-old asthmatic referral from the family school specialist. Johnny is being referred for multiple school absences in excess of 30 days. As I drive up to Johnny's home, I see a very small little boy standing in front of his home, which appears to be in great need of multiple repairs. He meets me at my car, asking my name, his blue eyes appearing somewhat dull. As we enter Johnny's home, a stench immediately overpowers me. His mother, appearing very thin and much older than her years, moves a pile of old blankets, making room for me to sit. Johnny sits close to his mother as we begin to discuss his health history. Johnny is classified as a severe, persistent, uncontrolled asthmatic with a history of physical abuse as well as failure to thrive. His mother has endured years of physical abuse from Johnny's father, and I also question potential drug abuse. Over the next few months, we try to provide linkage of services with various community organizations to meet the patient and family needs. For example, a local community church provided rent for the family on various occasions. The Evelyn Foundation provided monies to purchase heating. Hearts with Hands provided food for the family. An organization provided counseling for the family as it relates to domestic violence, and various other entities provided services. We work in partnership with the patient's primary care provider to optimize patients' quality of life. We begin to gain control of Johnny's asthma, and he begins to grow and thrive. The family continues to struggle to meet their financial obligations. Despite our efforts, Johnny and his family are evicted from their home and are homeless during the Christmas holidays. We work with various organizations, specifically the Housing Authority, to try to find affordable housing for the family. Our efforts are unsuccessful, and the family is forced into a hotel room with all of their belongings. We work in partnership with various department stores to provide Christmas gifts and food for the family. Johnny is very excited about his gifts and isn't complaining of hunger any longer. While living at the hotel, our suspicions about potential drug abuse and prostitution are confirmed. A referral is made to DSS and Johnny is placed in the custody of his maternal grandmother. While in his grandmother's care, Johnny's asthma continues to improve as well as his school attendance. Last year, Johnny had perfect school attendance and his asthma is now controlled. He continues to live with his grandmother and appears to be doing well. His mother was recently released from jail and has received counseling and rehab services. She's allowed weekend visitation. Mission Health, founded in 1885, is the regional care center for Western North Carolina and operates the only children's hospital, Mission Children's. 1 out of every 4 children in Western North Carolina lives in poverty, which has a high minority population of Native Americans, African Americans, and Hispanics. Among racial groups, persons of multiple race have the highest asthma prevalence as well as individuals with lower income to poverty level ratios. Over 70% of our children receive care at Mission and are Medicaid recipients. A temperature climate with over 100 species of trees and 1,600 species of flowering plants, the legacy of tobacco, and high levels of poverty combine to create relatively high rates of pediatric asthma and significant exposure to environmental triggers that may exacerbate asthma symptoms. The Regional Asthma Disease Management Program was created to address health disparities in underserved and impoverished children suffering from asthma. Every 5 years, the Buncombe County Health Center, in partnership with other community agencies, conducts a community health assessment. In 2001, the results prompted us to develop the Regional Asthma Disease Management Program, which acknowledges the local population's healthcare habits and asthma care needs, specifically delivering asthma educations and interventions beyond the clinical settings in homes, schools, child care centers, and other community sites. The Regional Asthma Disease Management Program incorporates the 6 key messages of the Guideline Implementation Panel Report of the underlying Expert Panel Report 3. Assess asthma severity, assess and monitor asthma control, use of inhaled corticosteroids, use of a written asthma action plan, allergen and irritant exposure control, and follow-up visits. Community, state, and national partnerships have been critical to the program's success. We have a strong core network of partners throughout the Western region that includes schools, child care centers, primary care offices, hospitals, as well as state and national partners. We utilize community partners and faith-based organizations to address social determinants of health for our families. The program from its inception has focused on the most at-risk and vulnerable children diagnosed with asthma. The majority of children served in the program are from low-income families and are uninsured or underinsured. The program components include lung spirometry, exhale nitric oxide testing, peak flow meter monitoring, and symptom diaries to assess risk of impairment, as well as exercise challenge tests as deemed appropriate. Each patient is seen every 8 to 12 weeks unless poor symptom control dictates more frequent interventions. Communication across the continuum of care is critical and is constant. We disseminate education and outreach products and services targeting patients and caregivers. Education targets the areas of increased asthma awareness and strategies to reduce environmental triggers in the home environment. All patients served by the Regional Asthma Disease Management Program receive individually written asthma action plans. Clinicians, patients, and families jointly develop the asthma action plan and share it with all caregivers, including teachers, coaches, school nurses, primary care providers, and others. This same group receives regular updates on the child's progress throughout enrollment in the program. The goal of the Regional Asthma Disease Management Program is to subjectively improve a patient's quality of life and an overall reduction in the exposure of all children in Western North Carolina to indoor air pollutants. Environmental assessments are conducted at child care sites, schools, and homes of asthmatic children. Each assessment lasts approximately 1 to 3 hours, and results are discussed with the site or homeowner. An 8-page home environmental assessment questionnaire, which was developed in partnership with the National Center for Healthy Housing, is utilized. The questionnaire uses a multi-pronged strategy to identify allergens and irritants to which the patient is exposed and sensitive. We use churches and charitable community partners to address the social determinants of health and provide cleaning supplies, pest control services, and home remediation. Additional follow-up is conducted if remediation is required. Health data collected includes level of severity, level of control, exposures to environmental triggers including tobacco smoke, allergens and chemical irritants, ED visits, hospitalizations, school absences, and quality of life questionnaires. The program also encourages people to create an asthma-friendly environment. These pledges are tracked as part of the program's overall health success. In 2009, the Regional Asthma Disease Management Program was one of 13 national asthma demonstration sites chosen by the National Heart, Lung, and Blood Institute of the National Institute of Health. The research study was submitted and approved by Mission Hospital's Institutional Review Board and the Research Institute. The study was recently published in the Journal of Asthma. Between 2009 and 2011, 50 children were enrolled in the National Asthma Control Initiative. The charts were audited to assess program effectiveness and found statistically significant improvements across all variables. The mean age of the sample population was 8 years. The male to female ratio respectively was 56 to 44%, 38% were Caucasian, 28% American Indian, 6% Hispanic, 4% Mexican American, and 24% African American. The majority of patients were moderate to severe, uncontrolled at time of enrollment. The results were generated by the Mission Health System Research Institute by parametric and non-parametric tests utilizing the SAS model. ED visits decreased from 158 at time of enrollment to 9 for a cost savings of approximately $142,000. Hospitalizations decreased from 60 at time of enrollment to 3 for a cost savings of approximately $687,000. The average number of days missed per child at time of enrollment was 17 days, which decreased to 9 days following intervention. Clinical variables also indicated statistically significant improvement in lung spirometry. Average percentage improvement in FVC was 7.2%, FEV1 was 13.1%, and FEF 2575 was 21.1%. It was inclusive of all subjects with SABA, oral steroids, or air trapping was evident. Exhaled nitric oxide also improved by 3.4 parts per billion. Local churches, youth groups, and charitable community partners, again, were utilized to address the social determinants of health and provide home remediation to our underserved asthmatic children and families throughout the region. Approximately $66,000 were provided in kind over a 2-year time period, including bedding encasements, roofs were replaced, HVAC systems were replaced, and it also provided food and emergency funds for many of our families. The second prong of the study involved environmental assessments conducted in child care centers as well as asthma in-services. From 2009 to 2011, approximately 3,500 children received asthma-friendly environmental interventions and 259 staff were educated. Of those, 93% pledged to create an asthma-friendly environment for our children in Western North Carolina. In addition, approximately 3,000 healthcare professionals, children, and families received asthma education over the 2-year time period. We have had the opportunity to implement 3 national asthma grants since 2007 and have had statistically significant improvement across all variables, including ED visits, hospitalizations, for a cost savings which has exceeded over $2 million. We were very honored to receive the 2012 Premier Healthcare Provider Recipient Award from the Environmental Protection Agency's National Leadership Award in Asthma Management. The Regional Asthma Disease Management Program embraces a holistic approach to patient care through compassion and patient advocacy. Thank you.
Our next speaker at this time will be David Fidel. David Fidel is an assistant professor in the Department of Clinical and Health Psychology at the University of Florida. David has done numerous research, and at this time, I'd like to introduce David Fidel.
How's everyone doing today? Excited to be here. Thanks for inviting me to present. So from the University of Florida, I'm going to present some preliminary data that we have from a asthma and weight management intervention that was funded by the American Lung Association. So no disclosures for this presentation. Would like to acknowledge some of the funding agencies, like I mentioned just a moment ago, American Lung Association, and also our Clinical and Translational Science Institute. I thought I'd start off the presentation by talking about pediatric obesity a little bit as it relates to this talk. So as you can see in the figure on the left, pediatric obesity has significantly increased over time in the past several decades. Unfortunately, current estimates suggest that about 17% of kids 2 to 19 are obese. So that's at the 95th percentile or higher for height and weight. And then 32% are either overweight or obese. And as you can see on the graph on the right, obesity, similar to asthma, disproportionately affects racial or ethnic minorities. It's pretty well established now in the literature, and probably about the past 5 to 10 years, that asthma and obesity are linked. So hopefully that figure that I just went to a moment ago, you sort of thought that kind of mirrors the prevalence of asthma, right? Not to the same degree, but we've also seen asthma prevalence increase in recent years. About 18% of youth who are obese have a history of pediatric asthma, and there's been some really good epidemiological trials that have showed that obesity is a significant risk factor for new onset asthma. So if you have a kid who is overweight or obese, they're anywhere between 52 to 60% more likely to develop asthma than a kid who's not, which is, I think, very meaningful. There's a lot of hypothesized mechanisms as to why this linkage exists in the literature. I'm not going to go into those in great detail, but just to sort of tip my hat to them, those include inflammation, things like cytokines across diseases, lung mechanics. Of course, if you have higher loading on the chest wall, that's going to affect your residual volume and other aspects of breathing and shortness of breath, and then even some comorbidities. So you can think about things like GERD or even depression, distress, those sorts of things that can be present across both conditions. So we know that weight status negatively impacts pediatric asthma outcomes pretty much across the board in both adults and children. In children, kids who are overweight or obese with comorbid asthma are more likely to have increased prednisone bursts, more likely to say that they have shortness of breath, increased morbidity, lower asthma-related quality of life, so they're not doing as well with their asthma, reporting subjectively that they're doing as well. They often report that they have more shortness of breath and poor asthma control. Good news, and kind of really the thing that sparked this trial that I'm going to talk about today, is that we know that weight management, it's a changeable thing, so weight's not static, it's a dynamic thing that we all sort of wrestle with on a weekly basis. Weight management can improve asthma outcomes. So this is the adult literature here, some of the points that in trials that have either used dietary interventions or physical activity improvements, those sorts of things, if we're able to make some positive impacts on weight status, then we see the asthma outcomes can kind of follow in a positive direction. So more improvements in quality of life, et cetera. At the date that we started this trial in 2013, there were pretty few overweight or obesity interventions for kids with asthma. To date, there's been a few that have popped up that have shown some positive results in this direction, which I won't go into. I thought it would be, with my time frame, I'll just talk about the one that we did, which was called the CHAMP study. Very proud of that acronym. One of my graduate students came up with it. Acronyms are really hard to develop, I found out, for studies. So it stands for the Childhood Health and Asthma Management Program. Like I mentioned at the beginning of my talk, this is for overweight or obese youth with persistent asthma in the age range of 6 to 12 is our target population. So this was a 2-year grant from the American Lung Association. It's a pilot study, so in contrast to the previous presentation, sort of put your pilot study hat on when you're when you're seeing these slides and these data, but still pretty exciting. So the first thing that we did in this study is we focused on developing our weight management component to the intervention. So we used a family lifestyle intervention framework. I don't know if you all have heard of that terminology before. It's really the gold standard behavior change model for pediatric weight management. The family part comes from we target both parents and the child concurrently with skills-based interventions over time. And what we did is we used one of the colleagues on this grant has some good data for a family-based weight intervention model that we adapted for our purposes. So some of the skills I thought that in particular this audience might be interested in for weight management included things like stimulus control. How many of you all like Oreos, ice cream? I'm sure everyone's going to raise their hand. One person was very excited in the back. You're in good company. I enjoy both as well. So my route to make sure I don't eat all the Oreos or all the ice cream in my house is to not buy it or to have my wife eat it or my child, whatever, right? Stimulus control means what it sounds like. So it's not having that stimulus in the environment as often as possible. Other sort of more adaptations to that construct could be things like making things out of eye level. So if you're thinking about kids 6 to 12, you know they're about yay high. So when they open the pantry, not having chips as the first thing that you see, but having a more appropriate snack item. Having apples on the counter instead of chocolate, for instance, would be an example. Parent modeling and family mealtime were big things that we targeted. So making meals more of a family process we know can not only reduce the amount of food, but increase sort of those non-specific factors in terms of parent-child quality and interactions and communication. We focused a lot on that. Healthy substitutions is one of my favorite. This is a very, very much sort of a harm reduction approach, meaning that we're not telling you that you can't have ice cream or can't have sweets ever, but we're saying how can we take some of the risk away from that. So whether that's reducing the frequency, the type, so froyo versus ice cream would be a good substitution. Et cetera. We have an example here that I think might be too small about how to do that with a school lunch. So instead of using white bread, using wheat bread. Instead of using mayonnaise as a condiment, use mustard. Those sorts of things can actually make meaningful change over time. And we did a lot of work on increasing physical activity, reducing sedentary activity. Pokemon Go was not available in 2013. I wish it was, because that seems like a very good skills-based strategy now, but we focused all on sustainable, gradual changes. So the lifestyle part of the family lifestyle means that we wanted these changes to be something that wasn't so drastic that a family could keep up with it over time, because that's sort of the name of the game in terms of sustained weight loss. On the asthma management side, I won't talk about this too much. It was sort of Asthma Ed 101. We talked about physiology, trigger control, and difference with controller and quick relief meds, focused on some very general asthma education. A bigger component for us in this trial was to weave in how asthma is actually not contraindicated with physical activity, despite a lot of parental beliefs in this population. So we actually worked on assessing those health beliefs with families and targeting improvements in physical activity gradually, letting families realize that shortness of breath through deconditioning is different than shortness of breath due to asthma. Okay, so our pilot RCT, it was a 16-week intervention. In retrospect, I laugh because it's really long. 16 weeks. It was a matched attention control design, meaning that we met with families for 16 weeks, face-to-face, in both conditions. In the CHAMP condition, which is what I just described, we focused on weight and asthma management. It was very skills-based. We did a lot of SMART goals, SMART meaning specific, measurable, attainable, realistic, and time-bound. So instead of I'm going to increase how much fruits and veggies I eat as a goal, that's a very non-specific general goal, right? We would encourage families to say, after group tonight, I'm going to go to the store, I'm going to buy apples, I'm going to place those on my counter, and I'm going to ask that my kid eat 2 apples before next session. That would be a more attainable, time-bound, and realistic outcome, hopefully, for a family. We focused on problem solving, so helping families overcome hurdles, and then also some behavioral management aspects. So kids don't like to make changes in their diet. They don't like to be more physically active by and large, and so we worked on ways to overcome sort of the I'm going to say no and fight you every step of the way components. And then in the health education group, it was focused more on just general health education, things like bullying, dental hygiene, those sorts of things that controlled for attention for us meeting with families, but not outcomes. Okay, so I'm getting the 5-minute alert, so I'll try to go quickly. Our inclusion criteria had to be overweight or obese, 6 to 12, live with your caregiver. Exclusion was that anything that contraindicated participation, so upcoming surgery, pregnancy, that sort of thing would make you disqualified. This is really small. Our trial flow, I'll just say, we screened 82 people. We randomized 25 to each arm, and then we ended up with about 14 to 10 in terms of comparison. So we're talking about around 25 people total are about to show. Our attendance was admittedly poor, so it was hard for families to come to group sessions once a week. They attended about half of them in the control group and about 9 in the, about half of them in the intervention group, about 9 in the control group. However, they really liked it when they were there. So across both conditions, the satisfaction, the scale here is 1 to 5, with 5 being the highest. They were really happy with the intervention. They were really happy with the control group. I think they liked feeling like they were doing something for their child's health. We were able to reduce sugary beverage consumption significantly over time. So kids in our CHAMP group showed a decrease that was statistically significant over time by the 6-month follow-up time point. We had really bad direction following with wearing those activity monitors. So you can imagine a 6 to 12-year-old wearing a monitor, a belt that goes around their stomach. Sounds like a great idea. As a researcher, I think a lot of kids really said, okay, I'll do it. And then they got in the car and took it off and never put it back on. Because we had about 32 observations, so we should have about 75 over time if everyone did it. We had less than half of that for this data. Okay, so just some brief conclusions with this pilot trial. Definitely learned a lot. People liked the intervention. They endorsed, we did qualitative interviews at the end, they endorsed this being meaningful and they really liking it. But I'm not sure how feasible this strategy is. There's pretty low attendance rates, a lot of barriers to participation. Kids got soccer practice, school issues. It's at dad's house on the, every other week was hard to come. Also, we had a pretty stringent control group, so lesson learned for me as a junior faculty is to not include a attention match control condition in your pilot trial. I would have done something in retrospect like a waitlist design or treatment as usual to see if there was some outcomes. Next steps for us would be to shorten our intervention length. I think we're going to try to leverage technology moving forward about how to deliver some of this material at a time that can be consumed at the pace of the family and not have to meet in a group session. I mentioned the potential comparator shifts of moving to a treatment as usual model, and then also thinking about other outcomes. So using risk-worn actigraphy and some other variables to assess. People have been interested in looking at airway hyperresponsiveness and those sorts of things following challenges that could also be good. All right, thank you so much.
David, certainly appreciate your talk. Our next speaker at this time is going to be Stuart Trossman. Stuart is just an outstanding person. It's certainly my pleasure to introduce him. Stuart is a professor of psychology at Jefferson College of Health Sciences and the chair of the Virginia Asthma Coalition. Stuart has published several publications in journals. He's chaptered many books. He has spent thousands of hours working on this conference, and we really appreciate everything and all the emails that we really received. And I certainly like to thank you, Stuart, for your mentorship during this time, being on the board and this being my first board meeting. At this time, I will present to you Stuart Trossman.
Over there, Virginia. Go over there. I can even do a little more mentorship. It's Stuart Trossman. So consider that a lesson learned. It's a pleasure to be with all of you here today. And I often get asked, what am I doing in psychology studying asthma? Obviously, I have asthma and so forth. So I'm going to be doing a presentation today with Lisa Johnson. 2007 guidelines said that that's very appropriate, but most education programs that we've looked at are not using evidence-based approaches. So we wanted to develop something that was group-based online, that was evidence-based. And the person that we really based this on, wasn't quite the right one here, but that's okay. I can go back and do a little verbal sharing. The program that this was really based on was a fellow by the name of Lev Vygotsky. Vygotsky came up with something called Constructivism. And Constructivism is the idea that if you're sharing information, the best way to teach somebody is to find out what they know first. How many of you engaged in doing some problem-based learning yesterday? Did people do that? What is that approach about? Can somebody just share what happens in a problem-based learning seminar? What do you do there? Does the speaker just get up and start talking and going over things? No. A case is given to you. The speaker wants to know how you problem solve, what you know. They want to know about your schemas. They want to know your knowledge. They start to teach you up. They do something called scaffolding. They do the teach me back. That's all based on the principle of constructivism, where you find out what your learner knows first and you try to get them to learn more. You don't just assume the empty vessel theory of teaching and learning, where you just get up there and start saying things because you don't know if they understand that. So we tried to really base this on Vygotsky's principles for teaching and learning. Whoops. So the goals for the current program were to basically keep that going. The other thing I need to share with you is we actually ran a program in Rockford, Illinois for many years. I was mentored by one of the founders of problem-based learning. His name was Howie Zeitz. And Howie mentored me, and we used to run programs in Rockford, Illinois, face-to-face programs like Weight Watchers, but just for asthmatics. We'd get small groups of people meeting once a week, and once they came in the first week, they loved the program. They would chat about things. We'd go around and we'd ask questions like, so what are you doing to take care of your asthma? And if we had somebody at the table say something like, oh, my asthma, yeah, my peak flow these days is at 200, but I take my albuterol twice a day, and when I have an episode, I take my Advair. Now, what do we know about that situation? It's completely wrong. But by sharing that, we wouldn't say, oh, that's wrong, you got to fix that. We'd be in a group-based situation, so we would say, so what do the rest of you think about that? If those of you who knew Howie, he was always doing that. We'd find out what other people think. We'd find out what people's schemas and knowledge were, and we teach them on those principles. So the idea was that worked out very well in a face-to-face way, significant improvements in quality of life, behavior change, asthma management. But the problem with that program is it was not sustainable. We couldn't really train other people how to do it because it cost a lot of time, a lot of money, and then you needed people, as David said a few minutes ago, to show up once a week for all these weeks. So what we wanted to do with this program is we wanted to see if we could preserve that type of program, but do it in an online way. And that was kind of challenging. So preserve Vygotsky's constructivist philosophy in developing an interactive group-based program. So by using schemas, another important concept for Vygotsky is something called the zone of proximal development. The zone of proximal development is where you ask the open-ended questions. Find out what people know. Find out what their zone is. If you ask me an asthma question, I'm an expert patient, so my zone is pretty high, but you could ask other people other things, or you could ask me a pulmonary or an allergy question. I probably wouldn't know it. So we want to find out what people know. We want to do scaffolding, teach me back, but we want to try to do this in an online way. So that was kind of the purpose of the program.
Pleasure at this time to introduce to you Lisa Johnson. Lisa Johnson has been a respiratory therapist for over 29 years. She's at Vedant Health And at this time, I'd like to introduce to you Lisa. She's been so passionate about asthma since about 1985. At this time, Lisa Johnson.
Sorry for all the mic switches, but they are recording us, and so we're sharing 2 mics between how many speakers? So it was a little challenging, but we made it work. Yay, okay. All right, so Stuart has gone over, and what he's going to do is he is going to guide us through the website, and so I will kind of turn to the screen because I need to see where he is. But while he is doing that, this really was a 6-month module that Stuart put together. He invited me to come and join along the way to help answer some of those really hard asthma questions. And I want to tell you, we had a ball over the 6 months that we put this program on. The first week was introductions. We said, tell us your story. And, to get the audience, the, adults to really participate, we told our stories first, and we added a little humor in there to get them going. And I don't know if you know Stuart, but he is comical, okay? And so y'all, he would put a little joke here, a little quirk there, and it just would get everything rolling like we wanted it to go. And that was the first 2 weeks. After that, and the first 2 weeks really required a lot of forms. So we showed them the NIH guidelines. Whoa, overwhelming, right? We kind of wanted it to be that way because we wanted them to start thinking. We also showed them an ACT. None of them had ever seen an ACT. We asked them to score themselves. So that was interesting to talk about the scores. Asthma action plan. They had not seen an asthma action plan. So at that point, me and Stuart knew that their knowledge of where we were was a little bit lower, so we kind of slowed it down just a little bit. But the website that we used was Group Site, very, very friendly platform. And really, it was free. We wanted them to interact, so we wanted it to be as easy as it could. And it was just overgoing. I mean, it's just overflowing with people, wanting to learn more. This could have gone on a whole nother 6 months, but we did have to end it at some point. So, had a great, great time. Module 2 was asthma basics. 3 was exercise. 4 was mind and body. That was interesting. 5 was behavior change. Can you tell us what you think the number 1 behavior change was going to be? Smoking, exactly right. And of course, number 6 was allergies. So to these posts, we had a lot of people to say, we want to learn more and more. So posting was like 40 posts per module, but viewed almost 300 times. Why do you think that they probably viewed it 300 times? Exactly. Process it and then respond back. Exactly right. And and some people are not going to respond until actually somebody else has posted. I don't know if any of you are used to blogs and stuff, but nobody wants to be the first one to respond, right? Okay. We even do that on emails. So some people were shy at first, but by the end, everybody was responding pretty quickly. After the 2 weeks, we did start with recordings that Stuart did. Again, very funny, very short, because we didn't want this to be very time-consuming for them. So he made it interesting and just entertaining. And some of the feedback that we got is, leave it to Dr. T to turn a pleasant discussion into an education. That is a great idea about the samples. The next time I see my primary care provider, I will ask about samples. Because, we found out that some of these people were paying out of pocket for these medications, and really they were struggling to afford it. Another one said, ha, ha, ha. Yes, leave it to Dr. T to teach us something. It was pretty cool to learn that the leukotriene only improves symptoms by 5%, while the nasal corticosteroids improve symptoms by 12%. That's a huge difference. But guys, if they didn't know it, they didn't know to ask it. So that's just a little bit about the website that we had there.
Okay, so I'm going to kind of conclude the presentation here. So as Lisa was saying, We had all this information up. We had a lot of views for each module, as she has kind of shared there, all the posts and all the views for each one of these. A lot of very interactive, humanistic conversations. Yeah, we were kind of amusing and socially friendly, but at the same time, we kind of hit them with the key educational messages of the guidelines and so forth. So we had a lot of posts, a lot of sharing, and a lot of discussion. At the end of the program, this is the comments, the qualitative. They had a good time and they learned a lot. It was very easy to do. So the program evaluation, when this was done, we asked them, what did you think about the program? They really enjoyed the social nature of getting to know one another, connecting with one another. They liked the education we shared with them. I had lots of abstracts up there, some articles. If they had extra questions, we would ask. It was great to have Lisa on board, because as most of you know, I'm just a psychologist. I have asthma, I know a lot, but Lisa is much more clinical than I am. And so that worked out very well. They enjoyed it. We thought it would go each module for 2 weeks for a total of maybe 2 months, but they wanted to do a module a month. And so it went on basically for 6 months, 2 months of open-ended discussion on their part. I make 2 10-minute recordings. They listen, comment on them, and then each month we move to a new topic. And so we got to behavior change right around New Year's, so that was a good topic to do, and then we wrapped it up. So we did it. It worked out well. I feel as if we were really able to preserve the constructivist-based philosophy. This is not problem-based learning per se, but we gave them stimuli and information, and it was really online. It was fun. It was educational. It would be very easy to train other folks. Now, it was not a research study because we didn't have a control group. We didn't really measure key outcomes yet, but it was just a pilot. In the future, we might do more with this. The big thing we're going to do in the fall with one of my colleagues over at Carillion Clinic, they have a pediatric practice, and we're going to actually run this with caregivers, and thinking that caregivers might be very good to be a part of this program. And hopefully over the future, if any of you are interested in becoming involved in this, Lisa basically was my co-facilitator. She learned by doing what we were doing. And then if she actually wanted to run the program on her own, she could. The group site is a free platform. The CDC uses it. So it's fun, it's friendly, and it worked out pretty well. Well, let me tell you what the toll-free hotline says. If you call up, it's the Psychiatric Hotline. If you call up and you've got obsessive compulsive disorder, just press 1 repeatedly. Okay? If you call up and you have multiple personalities, please press 2, 3, 4, and 5. Okay? If you call up and you're depressed, it doesn't matter which number you press, no one's going to answer. And finally, especially in this room, if you call up, if you have asthma, please don't call. We hate heavy breathers. You sound obscene and you won't get what you want anyway. So with that being stated, I think that kind of closes off our presentation, and I think that'll do it. Thank you all very much.